we going into the next case? Yes, case number 3.
Yeah.
Another 92-year-old.
Like a machine.
Dr. Sharma, is
No,
that
get
you?
the mic,
Are you on
Dr. Babar,
like Bewitched?
mic for him.
Like Piers.
Tower.
So
You go to tower.
92-year-old
Done
with
ready for
dyspnea
tower
and
within
on
5
minimal exertion, mitral stenosis
Okay.
here with a mean gradient of 8 millimeters and a mitral valve area of 1.5
Okay.
So-
and mild pulmonary hypertension.
All right, so just to recapitulate quickly, you can hear me now, right?
Yeah,
Good,
I did your
92-year-old.
case already.
Actually, patient again. What happened is this patient, these elderly patients, and this is where the whole question was, that do the routine angiogram in these patients. So anybody who go for a structural heart case, this you can see how calcific the mitral annulus is. Patient has a valvuloplasty long time ago, but came for the evaluation of TMVR. With the calcific mitral stenosis, but was found to have a very significant coronary artery disease. So let's go to the angiogram quickly. Yeah, where is the end?
Just ready to cross.
Okay, so now, as everybody said, this case we started with
No, the SS is live.
Is the panel happy now for the radial?
Okay, so please, Dr. Sharma, let's focus on the case now.
Okay.
Mitral
Good,
stenosis.
So I know there are a lot of radials, so that we want to respect the radial people, radial gurus. And here with the left
Radial.
guide is what?
VL30 guide.
It's a VL30 from the left radial. And my associate Babar did the case along with our fellow. And you can see here, 2 lesions, distal left main.
But this is the one that we thought
there's
about.
an additional lesion in the mid LAD. And the whole question basically was that we said, let's put a 90% lesion of the LAD, put a stent there, which has been done. And then you can see here, so then they did an IVUS of the both left main to LAD and left main to circumflex, because the initial angiogram, we felt there was a disease in the distal ostial circumflex also. See this picture?
Dr. Sharma,
Yeah.
just 1 minute. Let's take a step back. We need to kind of follow this case. So mitral stenosis patient comes in for a TMVR, but you basically do an angiogram and you're seeing this severe multi-vessel disease, the LAD, the left main, and now the question is how to proceed with this. You've already stented in the LAD, and now you're talking about the left main, correct?
Right.
Everyone on
That's
the
it.
same page? Okay, good.
Let's get everybody
Great.
on the same page. So
Okay,
good.
great.
Okay, now we can show the IVUS. So let's see how many people will say that there is a disease in the distal left main, there is disease in the distal prostial LAD, there is a disease in the ostial circ. So you take the opinion.
Yeah, that's a good, actually, leave that angiogram up, because that's where we
That's your working
start.
view.
That's the
Thank you.
working view.
Right.
That's the angiogram we need to look at. So
Yeah.
please don't, we're getting dizzy with the multiple angios.
Okay.
So this view is a perfect view. It's a working view. It sees what's going on.
Right.
Let's hear from the panel. I want 3 people to comment how they would proceed. I'm going to choose. I'm going to Antonio, Paul, and Raj Makar. Antonio, how do you proceed? You see the working view right here. The left main is the one that really is the question. The LAD they took care of already. So tell us how you would do this.
I think what they are doing is exactly the same I would do. I think radial is fine. I would take care of the LAD, which is obvious critical. Most probably will be critical the left main, but I think to do IVUS, it's a good idea on both. So I would do that and then make a decision.
We are going to show you the
So any
IVUS now. Show
well,
the IVUS left
yeah, we
to
see.
LAD.
So they're going to do imaging. Paul, as they're showing
So
us the
I would have done Colotte last year now,
Colotte.
because
Now?
I prepared for this presentation. DK Crush 5 study says that DK Crush is best for this. So maybe I'd have to do DK Crush.
So maybe you would have to do DK Crush, but Dr. Colombo doesn't care about the data. And Raj, how do you go forward?
Yeah, I would do IVUS and then go ahead and use, and if it is significant, then I would go ahead and use my standard
I
technique.
mean, it looks.
2
yeah.
stents.
Yeah,
If the
LAD
circuit,
and
What is your standard
the very
procedure?
Yeah, but this one I would FFR
left
this.
main and
You would
ostial
FFR
LAD.
this.
I would FFR.
So,
Yeah, I think
so
these
did you
lesions
hear
are
that?
very hard to
Somebody
interpret.
we got Mark Reisman here. He wants you to FFR this
No, he's
lesion.
already IVUSed it, but I would have done it as
the
a first
question
step.
here is the circumflex lesion. Left main LED is significant. The
Yeah.
question is the circ. Now go to the circ now.
The circ.
Left main to circ. That's the whole case here.
Right.
Yeah.
So
It
whether it's
looks
a 111
significant angiographically.
No, but I can
so-
tell you the FFR will not answer the question whether there is a lesion in the circ.
Yeah, show us the IVUS.
Good.
This is it?
Go.
IVUS run?
Okay, this is the
IVUS
IVUS run of the circumflex going into the left main and concentrate on the ostial circumflex.
So here we are coming back, pulling back with coming right into the, and here's the circumflex coming in and very close to the left main, and here
That's
it
it.
is.
There is
So,
no disease in the
it's not
ostial
bad. I mean,
circumflex.
I don't
Not so
see,
bad.
doesn't look bad. We don't have to
That's
do
it.
anything,
So
we're
there-
done.
Therefore, this case is 110. It's
Yeah.
not the DK crush case. DK
Yeah.
crush was either 011 or 111. So this is not the DK crush, and with that age, I would not even do a DK crush in 92-year-old. I think with the short lesion, even if it would have been a ostial circ, I would have done the cutting balloon. We have done the cutting balloon or no?
Not yet.
So
Ostial
the
circ.
data
We
doesn't
don't need
matter,
it
I
now.
get it,
We
but
don't
the
need
data
to.
does say
We are going to do a
Yeah,
cutting
correct.
balloon of the left main LED and put a
But in
stent
the
now.
92-year-old, you might want to just do something
325.
quick, right? And get the best possible. And because it is a little bit complicated with the
Samin,
DK crush.
did you do
More
IVUS?
time, more, yes, Raj, go ahead.
I just wanted to know if they did IVUS from left main into the LAD.
Yes, they did. That was the first run.
The first IVUS
That was the
And what
first
is
run.
that I didn't see, so that was
Yeah,
bad?
that was a
That
very
was
tight
bad,
lesion
severe.
there.
Tight lesion there. And so now it gives you the idea that you could go across the circumflex into the, into the LAD and left main and stent. Dr.
Rasana,
Samuel.
Why would you say that 92-year-old you will do whatever is easy and get away with it? She has
That's
a
a
normal
good point.
ventricle, no other problems. She should get what is the best.
Yes, of course. So Dr. Sharma, you're going to do DK crush here if you were going to. It looks to me
that's
you're
the
going
question was,
provisional.
But I
the
think it's a
plan
very
was
focal
that
lesion in the circumflex.
If there
You
was an
don't need to
ostial
do two
circumflex
stents.
lesion, then a
It's a
plan
very
was to do a
short
DK
focal
crush,
lesion.
yes.
We're bad.
One stent would be
Okay,
fine.
you're going over time because you're cutting into our coffee break. So
Yeah, 1 second, not yet, no
But
coffee yet.
we're not going for coffee. But,
Yeah, yeah.
but I want to just remind you,
Yeah.
we do want you to show us things, but
Yeah.
just
No,
reminding
but,
you of the time.
1 minute, I can tell you, we have done the cutting balloon with a 3.25 left main to LED. I have a wire into the circumflex, and with this is a 4.0.
4012.
So 4.0, what do you have?
Yeah, 4.0. Yeah, this is the 4.0.
Oh, I see Usman Babar. Hello, Usman. It's nice to see you there. Okay, good. So cross, there you go.
Yeah, 1 second. Yeah, little die. Good. Go
That's
up.
nice. Good.
Yeah, go to 16 atmosphere.
That's something there.
Yeah, clearly disengage the guide, your wire is there, negative. Go up again. So proximal maybe 4.5, we can take a 8 millimeter balloon and just open proximal requiring, and if it looks good, I would just leave it alone.
Yeah.
I mean,
Yeah, maybe it
particularly
sounds
here the
like
plaque modification.
provisional here. Yes?
Yeah.
Paul, you're
Well,
good with
I mean,
that?
Cindy and I will debate that in a few
Yeah, I
minutes.
know. I can't wait for these debates. They're going to be fun today. But yes, you and Cindy going up against each other about provisional versus stent.
But
All right.
basically this case.
So we are done here, and if it's okay, you can go to that our tower case, valve in valve,
Oh,
in
yeah,
room
yeah.
6.
We have a case.
Okay.
All right.